we covered a little bit in the first two talks, I think, but it's in the context of athletes and the pre-participation evaluation. So, first, the topic I was going to talk about is just talk about some of the common causes of sudden cardiac arrest and sudden cardiac death in athletes. Briefly review some of the guidelines for eligibility and disqualification for specifically competitive athletes. Go over some of the history and physical exam portions of the pre-participation evaluation, including going over some of the red flags to pay attention to. And then the last part, we'll kind of talk about emergency action plans and secondary prevention for sudden cardiac arrest. Luckily, sudden cardiac arrest and death in athletes is a very rare event, but obviously it gets a lot of publicity when it happens because it's a scary thing, and you're looking at an otherwise healthy adolescent that has one of these events. It's usually due to an unrecognized cardiovascular condition. The true prevalence isn't really known. At first, it was thought maybe it was only 1 in 200,000 per academic year for high school athletes, but more recent studies, including those of NCAA athletes, it's closer to probably 1 in 50,000 to 1 in 80,000. About 0.3% of athletes probably have a cardiac disease that could put them at risk of sudden death. The highest risk groups are going to be males, African-American athletes, and sports that is higher risk is basketball. This is kind of a little bit of an old diagram, but kind of breaks down the most common causes, with hypertrophic cardiomyopathy being the most common. There's this indeterminate LVH. Some people, there's even categorized as idiopathic LVH that may be on the spectrum of hypertrophic cardiomyopathy. Coronary artery anomalies are second. Arrhythmias, specifically channelopathies, are in that next group. But I think it's important to keep in mind, recent studies have shown about 40% of athletes who die suddenly don't have an autopsy. And then a negative autopsy doesn't necessarily give us additional information, because things like channelopathies and arrhythmias will probably have a normal autopsy. So this is kind of changing as we get more information. We have genetic testing that kind of help out a little bit. But the things we'll focus on with the next few slides will be hypertrophic cardiomyopathy, coronary anomalies, and the channelopathies and arrhythmias. So this is kind of the differential, and I just put it up there to mostly highlight that a lot of these, it really is genetic causes for them. So the blue ones, are typically inherited anomalies, cardiovascular disease. So with hypertrophic cardiomyopathy, as I mentioned, it is the most common cause of sudden cardiac death in athletes, about a third or more of cases. Initial estimates were about 1 in 500 in our population has a genetic hypertrophic cardiomyopathy gene, but maybe closer now, again, with genetic testing giving us more information, closer to 1 in 200. It's typically inherited in an autosomal dominant fashion, but there is sporadic mutations. And one of the challenges is there's variable penetrance. So you could have the gene, but not necessarily manifest signs of hypertrophy. So again, more things we're kind of learning as we do more genetic testing. It's really due to a defect of the genes that encode the sarcomere protein. So it causes a mutation in the contractile proteins of the myocardium, and it causes some myofibril disarray that is a substrate for arrhythmia. So ventricular arrhythmias is usually the cause of sudden cardiac arrest or death in these athletes. So this is just kind of an echo view. Oftentimes the LVH is asymmetric. This one's showing a lot more of septal hypertrophy. And you can kind of imagine with the contraction, there's potentially some LVOT obstruction. So about 25% of patients will have at rest LVOT obstruction, but over 50% we can manifest it when you add exercise. We'll see some LVOT obstruction. So patients may have symptoms before they would have a sudden cardiac arrest. So a lot of times that may be chest pain with exertion, dyspnea with exertion that's out of proportion to their level of activity, palpitations, syncope would be a big red flag. But a lot of patients may be completely asymptomatic, and sudden cardiac arrest or death might be the first clinical manifestations. On exam, there may be a murmur of dynamic outflow tract obstruction, and sometimes you can induce that by doing a maneuver, specifically having them stand and listen, which will bring out the LVOT murmur potentially, or Valsalva as well. So those positional, examining both laying and then upright or with Valsalva is important. And then about 70 to 90% of cases will have an abnormal EKG. The hypertrophy pattern may influence the EKG. There's not really a typical EKG pattern, but a lot of them will have some, especially inverted T waves. If you see inverted T waves in V5 and V6, that's very abnormal. Sometimes some ST changes, and then pathologic Q waves. So these are just two examples of some EKGs of a patient with hypertrophic cardiomyopathy. So the second most common cause, and this is the one we fear, I think, as pediatric cardiologists that we don't want to miss, is anomalous origin of the coronary artery. That can be either anomalous origin of the right coronary from the left coronary or cusp, or the left from the right. The left from the right is the one that is the most concerning. We do pick up patients who have an anomalous right that often is picked up incidentally, and that's always causes us a little agony to figure out how worried we should be. But anytime we see the anomalous from the left, or anomalous left coronary artery, I should say, that's the one where it has the highest risk of sudden cardiac death. So this is just an example of, so the schematic is just showing those two different types. And then this is just an echo image. And I think the reason I picked this one is this one, if you just had the 2D picture that's on the left, you can be fooled that looks normal. So when we add the color, it tells us the direction of flow and whether we see coronary filling. And sometimes it's actually seeing some abnormal flow is more concerning or tips us off than anything else. So in this picture, it might be a little hard. I don't think I can slow it down, but you see this kind of funny little red flow right at about the 12 to 1 position, and that's showing an anomalous left coronary artery taking this, we call it intramural course. So it kind of hugs the aortic valve annulus to move over when it gets over into the normal distribution of the left coronary. So if you order an echo, this is always my little tip, make sure you're having it done by a place that can actually evaluate this condition if you are doing an echo for, chest pain with exertion, for example, because getting an echo that says normal without confirming flow, you could be a false negative. So symptoms may be present before this is diagnosed. Oftentimes that could be chest pain or syncope with exertion, but again, a lot of times may be completely asymptomatic until a sudden cardiac arrest. Physical exam is going to be very normal, and then your EKG at rest will be normal as well. So the other kind of big subclass of causes of sudden cardiac arrest and death in athletes are arrhythmias, and a lot of these are these inherited channelopathies like long QT syndrome, Brugada syndrome, or catecholaminergic polymorphic ventricular tachycardia, or CBVT for short. And then there's also Wolff-Parkinson-White, which isn't technically something we think of as inherited, but is definitely something that has been associated with sudden cardiac arrest in athletes. This likely, as I mentioned before, is likely an underestimate because autopsies are going to be negative. So unless you are doing a family history or do genetic testing or test family members, you could have a negative autopsy and you're saying you don't know the cause, even though there was a cause. So, when you're kind of investigating this, because a lot of these are inherited, it's important to remember to really ask about family history, especially sudden death, family members who've had, syncope for no clear reasons, or sometimes even like a history of seizures may actually be arrhythmias inducing the seizure, not really epilepsy. So with long QT, often asymptomatic, but sometimes can have palpitations, pre-syncope, syncope, or again, seizures as initial presentation. About 10 to 30% of patients will present with sudden cardiac arrest, 33% present with syncope, and then about 10% end up initially having what's diagnosed as a seizure disorder, but then found out it's actually they have long QT. The syncope and the sudden cardiac arrest they have is due to episodes of polymorphic ventricular tachycardia or torsade. And that really is when that arrhythmia degenerates into a ventricular fibrillation. Involves a defect in the ion channels of the cell membrane that results in an abnormal myocardial action potential and prolongs the QT interval on the EKG. Type 1 is going to be the most common, and that can be triggered with exercise. And swimming is one that we worry about. So another thing with family history, if there's a drowning, but of a very competent swimmer that wasn't from, being in the ocean and being pulled out, swimming pool drowning would be kind of odd. So just kind of sometimes you get those little pieces of the history that you kind of might put two and two together and figure out this doesn't quite make sense. So can also be associated with congenital deafness. There's both autosomal dominant as well as recessive types, and then we acquired with certain medications or a combination of medications. And this is just an EKGs showing, the top one is really showing this prolonged QT interval. This one you can kind of see without even measuring it. And then the bottom one is just showing what the torsades, that kind of twisting ribbons appearance. And then CPVT is also one of these, again, inherited channelopathies. And this one is with exercise typically is when it manifests. So, if there's a history of episodic exercise or emotional induced syncope, that should be kind of a red flag. And again, it's the catecholamine is what kind of induces it. So with exercise, obviously there's a high catecholamine surge, and then anything that might be emotionally triggering might be something else that this might manifest with. It's due to a mutation in the ryanodine receptor or the calsequestrin 2 gene, which results in some abnormal calcium regulation. There's both autosomal dominant and recessive forms as well as sporadic mutations. Typically, it won't manifest until late childhood or adolescence. And what happens is it results in this polymorphic ventricular tachycardia that then can degenerate into ventricular fibrillation. EKG and echo are going to be completely normal at rest. So oftentimes this gets diagnosed because we have a high index of suspicion. We have them do an exercise test, and during exercise we see a lot of PVCs, some polymorphic VT. That would be kind of how we would diagnose that. Brugada is another channelopathy. It's pretty rare, but it is one of those things we would have on our differential. It's due to a defect in this sodium channel. Not as common in younger patients, but can manifest during adolescence and adulthood, with sudden cardiac death being the initial symptom. A lot of times it happens in sleep because there is more commonly will cause this arrhythmia during lower heart rates, bradycardia, which is another reason athletes might be a little more prone because of high vagal tone from their conditioning level. But fever can be a trigger. There's a characteristic EKG pattern, which is really in V1, V2, and sometimes into V3, where we see this kind of upstroke in between the kind of ST kind of area. Sometimes it gets misclassified as a right bundle branch block, but has a very different look to it than a right bundle branch block would. If we have a high index of suspicion, if we don't see it on a resting EKG, then I think what was brought up in the previous talk is doing a procainamide challenge would be something to consider. And then one of the pieces, they might have a history of syncope, might be how you diagnose that or how you might suspect it, along with family history. And then Wolff-Parkinson-White is probably the most common arrhythmia we might pick up, just because it's going to be more common than a lot of those channelopathies. It's less likely to result in sudden cardiac death, but there are some types that will increase your risk of it. And we can't really tell with just a resting EKG if it's going to be the low risk versus a high risk type of Wolff-Parkinson-White. Usually there's symptoms of palpitations or runs of SVT. Oftentimes they're kind of sporadic, may most often occur at rest, but it can happen with exercise, as I think James's case this morning showed. I guess his with the SVT, but the point being SVT can happen with exercise. But when there is sudden cardiac arrest or death associated with it, it really is because there's some rapid conduction through that accessory pathway with Wolff-Parkinson-White that results in ventricular fibrillation. And it's that pathway has specific properties that make it more of a fast conducting pathway that would be a high risk pathway versus some other pathways and probably most pathways with Wolff-Parkinson-White are going to be the slower pathways that don't have that same risk. So just having Wolff-Parkinson-White, I guess the point being is it's not necessarily you're a high risk. There's certain ones that are, but it's hard to differentiate without having something like an EP study that will give us the properties of those pathways. But Wolff-Parkinson will have this very typical pattern. We see that delta wave, which is the pre-excitation with a shortened PR interval, as the EKG on the right shows. The next things I was going to mention are just other things that we have to think about. So Marfan syndrome, probably the big concern there is aortic root dilation, which can increase the risk of dissection. And so that can happen more commonly with high intensity or contact sports. So when we diagnose this, we might have to put some exercise restrictions on patients. They obviously have a certain body habitus, which may make certain sports, they may be more inclined to start playing. So, those very tall kids, not every tall kid obviously has Marfan, but tall or have that wide wingspan. So they definitely have these very characteristic physical exam findings that would be suspicious for Marfan syndrome. And then myocarditis and some other cardiomyopathies are also things that we kind of think about and can happen or result in sudden cardiac arrest or death. So myocarditis results from inflammation in the myocardium, usually after a viral illness. So there's some usual viral prodrome before the myocarditis develops, which can lead to myocellular damage, and that increases risk of arrhythmias, can cause ventricular dilation and dysfunction. The risk of arrhythmias especially is higher during that acute inflammatory phase, which there are definitely been cases of athletes who've had unknown myocarditis. Those, winter season, get sick with some, whatever's going around in the school. They're still going to play in their basketball game or whatever winter sport they're doing. And that's usually kind of what you typically hear in the history is, they were still playing despite probably being sick or not feeling well, but as a lot of athletes do, they push themselves through and still try to play. Dilated cardiomyopathy, often idiopathic, can also be inherited, causes heart failure. Big thing would be worry about sudden cardiac death is risk of arrhythmias. And then one of the other cardiomyopathies we have to pay attention to or think about is arrhythmogenic right ventricular cardiomyopathy, or ARVC, also inherited. It's more common and people with Italian, especially North Italian heritage. It was very concentrated in that area, but I think it's about 1 in 2,000 or 1 in 1,000, risk or prevalence, I should say. And it causes this scarred appearance of the RV free wall and some fibrofatty infiltrate of the myocardium, mostly of the right ventricle, but more and more we're learning that the left ventricle can be affected as well. Increases the risk of ventricular arrhythmias is the big concern. So there might be a history of palpitations, pre-syncope, syncope, or atypical chest pain with these patients. And then congenital heart disease, obviously as pediatric cardiologists, we follow a lot of these patients. They grow up after they have their surgeries, they want to play sports and be active. And luckily, in general, with congenital heart disease, it's not typically a much increased risk of problems with athletics, other than the coronary artery anomalies. So sometimes significant aortic stenosis can cause a sudden cardiac death. But a lot of those patients, we actually know they have this history. We are getting frequent cardiology evaluations, and we have very good guidelines to help us decide, whether to clear patients or not. I put this picture up of Shaun White because, as maybe many of you know, it's also the Winter Olympics. He has tetralogy of flow, and he's obviously competing at a very high level. So we really try to make sure our patients are active and try not to unnecessarily restrict them just because they have congenital heart disease. So that brings me to the 2025 very new guidelines we have that help us decide how we should, if we should allow patients to still participate in sports, if we have to restrict them, how would we restrict them? This is updated from the 2015 guidelines. A lot of things stayed the same, but one thing I think it's using a lot more is this shared decision-making with the family and realizing that even patients with the same underlying heart disease may not be at the same risk. So we're learning more about risk profiles and what patients might be higher risk that we're going to be more limiting, which patients we actually can probably let them play sports more than we used to. I think we used to a lot more restrict, and now we're kind of gearing towards not restricting as much because we really want our kids to be active and not develop other heart problems like coronary artery disease. So I also think I always want to mention too, when we're talking about restriction, this is really for competitive athletes. And really that's going to be maybe some of those middle school athletes doing club sports, but really high school and college athletes. The young kiddos, I actually tell all my patients at that age, play sports, have fun. There's so many other good things about the social aspect. When you watch kids play kick and chase soccer, they're half the time they're walking, but they're outside, they're not on their screens, right? And then I also say expose them to everything, because if we get down the road and we do have to start restricting, not every sport's the same. So then we have at least options. We're not like killing a kid's, like desire to be the best soccer player because they've been playing a lot of other sports the whole time. If we have to limit one sport, but we can allow them to play another. One of the things that's very clear in all of these guidelines is that firm disqualification should be confined to individual athletes with probable or conclusive evidence of disease rather than those with borderline findings. So we really, again, I want to emphasize minimize unnecessary restriction from sports or give stigma of or cardiac disease. So we may be, by taking that stance, permitting the occasional athlete to participate who may be at some other risk. And again, this is where that shared decision-making with the family and athlete come in. And this is also where, awareness of AEDs and, what's available in the sports field is probably part of that conversation as well. So it's not as binary, yes, no. There's a lot more nuance to these discussions to have. And it's also important, not all sports, again, are the same and have the same level of intensity. Some are going to be more aerobic, some are more isometric. So there's a lot of variety in those sports. So sometimes you're gearing kids to one over another just because one is okay with their cardiac lesion, another maybe not so much. And then I also talk a lot about just the conditioning that goes into playing that sport. So maybe the sport itself isn't that much when you're in game time, but all of the weight training and conditioning ahead of time, we might have to put some limitations on or modifications, even though we're going to allow them to still play the sport. So this is just a diagram just showing how we might categorize those sports and how they're not all equal. So going up, we have increased static component, and we get up to high, those are things that are going to be a lot more isometric. So some things like, if they have a dilated aorta, we may be like, we don't really want you doing heavy weightlifting or wrestling or these kind of more isometric. And then there's some that are going to be more on the dynamic or aerobic side of things. So pretty intense aerobic that, there's certain conditions we may say not as good. And then there's others that are just somewhere in the middle, and that would probably be okay for most of our patients. There are some recommendations. I didn't see any updated ones. These are from 2004, but for just helping patients who, we've said you can't play competitive sports, but we still want them to be active and they know they have, one of these genetic conditions, hypertrophic cardiomyopathy or Marfan or some of the channelopathies, and just help guide them into what recreational sports. Because again, you can get pretty crazy with your recreational sports too. So kind of be a helpful guideline for those patients. Okay, so the next kind of shift in the talk is I just wanted to go over the pre-participation evaluation. And really the goal of that evaluation is to appropriately restrict, but also appropriately clear athletes. It's important to be thorough and conscientious. And then really you're looking for any warning signs, either in the personal or family history. So the AHA does have this 14-element cardiovascular screening checklist. The OSA uses this. So if you're using the OSA pre-participation evaluation, it's going to cover all of this. 7 parts are the personal history. So those are kind of things like chest pain with exertion, unexplained syncope or near syncope, excessive exertion or unexplained dyspnea, fatigue, palpitations, again, with exertion, prior history of a murmur, elevated blood pressure, prior restriction from participation in sports, prior testing for the heart ordered by a physician. And then there's other 3 points that are family history. That's going to be premature death, especially before the age of 50. That's due to heart problems, disability from heart disease in a close relative. Again, usually we're talking about first-degree family members. And then kind of trying to see if there's at least any of these heritable or inherited conditions like hypertrophic cardiomyopathy, long QT, other channelopathies. So that's going to be the family history component. And then there's 4 points of the physical. So heart murmur, again, thinking about that sitting or laying and standing, or with Valsalva, you're trying to induce that outflow tract obstruction murmur with hypertrophic cardiomyopathy, checking for femoral pulses to exclude coarctation, looking for any physical signs of Marfan, and then blood pressure. And that's, so those AHA recommendations are also kind of supported by the physical exam that's endorsed by the AAP, the AAFP, all the sports medicine organizations as well. They kind of have a little bit different, but pretty similar as far as, things that you should cover with that evaluation. So with the medical history, I think it's important to both interview, if you can, the athlete and the parent, because they may have different, concerns that you want to make sure, or different observations. So it's important that the parent can, help with that process. Asking open-ended questions is obviously good. And then still, again, having that checklist that you're using to help probe for those potential cardiac disease. So with a personal history, it's really a focus on exertional symptoms primarily. Chest pain when sitting in class, probably not too concerning. Chest pain when I'm doing a pretty high exertional sport, a lot more concerning. So really focusing on the exertional symptoms primarily. And then also important to get a detailed medication history, both prescribed medications and supplements. Some teen athletes, they are using some different performance-enhancing drugs or supplements. There's a lot more out there that I realize. I have a teen son, and he tells me some of this stuff, and I'm like, people don't even know what those things do. I don't know why they're using them. And then energy drinks, huge in the teens. So, asking about those things too, I think is important. And then for past medical history, asking especially Kawasaki disease, myocarditis, pericarditis, congenital heart disease, history of murmurs, those kinds of things. And then again, family history is often underestimated, but it's a big piece of it, right? We already, I mentioned a lot of these are inherited conditions that put athletes at risk. So you're really trying to ask some specific questions to figure out if there should be a concern. First degree family members, most important, but at least going back to grandparents, aunts, uncles, cousins can be helpful to just kind of piece together if there's any pattern that you're seeing in the family history. Of course, this is hard when there's a lot of estranged families or parents don't get along and you don't know this side of the family or that side, but as much as you can, getting that family history, it can be helpful. And then with the physical exam, blood pressure is really important. Probably not necessarily something you'd restrict, but obviously if you're seeing high blood pressure, there might be things you'd want to, rule out and make sure that you're not missing. And there can be high blood pressure in, kids who are overweight or have family history of high blood pressure. Looking for Marfan syndrome again, and then that auscultation. So the AHA does recommend that if you have a positive response at any of the 14 recommended items, again, it depends on the history, how your, what your index of suspicion is, but it can trigger referral to a cardiologist. Doesn't necessarily mean you should restrict them. A lot of times you can still let them play until they get their evaluation, again, depending on what your concern is, what kind of history you're getting, what kind of sport they're playing potentially. But, again, as we talked about with some of our previous talks, things like syncope with exertion, big red flag for us as cardiologists. We definitely need to rule out more concerning underlying cardiovascular disease. Chest pain, discomfort with exertion, probably less likely to be cardiac. Exercise-induced asthma is going to be more common, or just chest wall or musculoskeletal pain, but because it's with exertion, we do raise that red flag. Excessive shortness of breath or fatigue with activities. Obviously, any of the family history, signs of Marfan syndrome, those kinds of things. So the last part of the talk, I really want to just focus on some secondary prevention. And that's really because we know no matter how good our screening is, even if every patient can get an EKG, even if they can get an echocardiogram, we're not going to 100% prevent sudden cardiac arrest in young athletes. Even at the NCAA level, they do a lot of additional screening, and they still will have kids go under cardiac arrest. It wasn't that long ago, LeBron James' son had a sudden cardiac arrest at USC. I mean, talk about a family that has every means and probably could hit every screening and is at an elite college. It still happens, and luckily, because he was at practice and they had emergency action response and AED, he survived. So I can't emphasize enough that this is, to me, most important because we can't prevent every potential sudden cardiac arrest in a young person. So having an AED available, having an emergency action plan, which includes not just the AED. You can have the AED, but if nobody can recognize a sudden cardiac arrest and everybody's kind of standing around or wondering what they should do, that's not very helpful, or at least initiating CPR, knowing how to do high quality CPR. Because really the goal is to activate EMS and get the AED on site or at the athlete within 3 to 5 minutes. That would be the goal. So just the recent American Heart Association Heart and Stroke Statistics update from 2026, survival for kids without a hospital cardiac arrest was only 17%. A lot of those are respiratory. As we know, cardiac is not usually primary cause. It's probably second, the arrest happens secondary respiratory, but still 17% isn't, I was surprised it was only 17%. And then of those who do survive, about 79% will have a good neurologic outcome. So presumably they got attention right away, got CPR right away, and that's why they had this good outcome. Sports-related sudden cardiac arrest accounted for 39% of the sudden cardiac arrests in those under age 18. And about 44% of athletes survived to discharge. So I don't like that number. I think it could be better if we had better action plans everywhere where athletes are competing or practicing and playing. So, again, I can't emphasize enough, rapid response with CPR and AED saves lives. It's the single greatest factor affecting survival from an out-of-hospital cardiac arrest is the time from arrest to defibrillation. The chance of survival declines by 7 to 10% every minute that defibrillation is delayed. So 7 to 10%, that's a significant amount with just 1 minute delay in getting an AED on and a patient defibrillated. When they looked at, there's a recent study that evaluated the survival of young athletes with sudden cardiac arrest if early defibrillation was achieved. So it looked at 1,710 high schools that had an on-site AED and presumably probably an emergency action plan. They had 36 cases of sudden cardiac arrest. I think this is interesting. 14 were athletes, but that meant there was 22 people who were also took advantage of this by being, they were just a bystander, coach, spectator, whatever. They weren't the athlete, but they still, because you had an emergency action plan, you had an AED, they got that care right away. So 94% received bystander CPR and AED deployed to shock in 30 of the 36. There were 64% survived a hospital discharge, which include 9 of 14 athletes. So much better than the previous statistics where, if you looked at all comers, it was less than that. So it did make a difference having an AED there on site. So, it's not, like I said, it's not just the AED though. It really is having this well thought out protocol that helps the most. It really helps ensure that there's a rapid, organized response to a very critical and very time-sensitive event. So that includes training and education on recognition of sudden cardiac arrest with clear steps in how and who should be responding. So it's a coordinated effort by the group that is there who witnessed the cardiac arrest. It's having an AED that's readily available, not on the other side of campus, not locked up, not with a battery that, didn't get checked and now doesn't work, or pads that have expired. So an AED that can be used immediately. And there's that rapid implementation of CPR and the emergency action plan and the emergency response services. So I did want to introduce this because it's something that we at OHSU, and I'm part of this, starting. So Project Adam is a national organization that was developed to help with these cardiac arrest action plans for schools. So it started in Wisconsin, and now it's throughout the country. And most states will have an affiliate where they help schools get ready to have these action plans, to have AEDs available, have a whole plan on how and when they should be checked. And then if they meet these certain criteria, then they can become a heart-safe school. So they have to have the AED, they have to have it accessible, they have to have it maintained, they have to have a designated cardiac emergency response team that's, also trained. They're not only is this team trained, but they're also training the school staff, not just teachers, but anybody who's going to be in the school building that would potentially witness or respond to a cardiac arrest. And then they have drills. So the school has to have some, kind of let's practice this, implementing some kind of drill and training as part of the checklist to be a heart-safe school. So we're starting it soon. We're in the process. So I'm just putting a plug in. If you have a child at a school or patients at schools and you think that there's some people in those schools who might be excited about doing this, definitely reach out. That's our email. What we would do as a Project Adam affiliate, we don't actually, a lot of this has to be driven through the school. Like, we're there to help coordinate, help, kind of provide some of the education, hook schools in with the community, whether it's the local EMS services, making sure that there's any CPR training that needs to be done, who in the community can do that. So we're not necessarily going out there and doing this for schools, but we're there to help to be a guide. And then if they want to go as far as getting that heart safe designation, then we would make sure that they meet all those criteria, but then could be designated a heart safe school. So I just wanted to play this because I think this, to me, drives home the point of why secondary prevention and emergency action plans are so important. Yeah, so that was just, I think, a very telling example of what could happen if you had a school that was trained. 4.5 minutes, you saw that how coordinated they were. They immediately got CPR. They recognized it. She was just at a volleyball game. She wasn't running and clap. She was just sitting there, and then she just goes over. And they immediately recognized she had a sudden cardiac arrest. They immediately started CPR. They got the AED and defibrillator within 4.5 minutes. They would have waited for EMS 11 minutes. And we already, I mentioned that for every minute, 7 to 10% decreased chance of survival. So I actually saw her interviewed in another talk. She's totally healthy, normal teen. She had it, I think it was an anomalous coronary, if I remember correctly. But anyway, I just thought that was a nice example of why that's so important.
Yeah, what a dramatic video, right? Wow, thanks for sharing that. Really hits home. Mm-hmm. Okay, questions for Dr. Carlson?
In terms of the family history is a red flag, because I feel like we get a lot of kids that their personal history is fine, their assessment is fine, but they have the family history that kind of zeroes them in. For example, we had a perfectly healthy female that wanted to play softball. They always wait to the last minute to get their sports physicals. Mm-hmm. But her dad has cardiomyopathy. And so we did a referral to cardiology, but they can't see her till April. So she can't do, so do you get an EKG and have her continue? Do you have her be sorry, you got to wait?
Yeah. I would take a lot more history of you said it was a dad?
Yeah.
Yeah, I would get a lot more history of the dad. One thing, it's a little pet peeve of mine because I've had several patients in a similar situation where, you're trying to figure out, was this an ischemic cardiomyopathy? Could it be genetic? Was there any other family members? And, you don't get a lot of positive answers. And then you hear from their adult cardiologist that, we didn't do genetic testing because it's not going to help us out. And I'm like, but it might help everybody else out. So I try to get a little more history if I can from the family because that might help to know, should I be worried it's genetic or was this just dad only kind of idiopathic or post myocarditis or something. I think an EKG, as we talked about this morning, is a pretty easy, quick test. And I think in that situation with a totally asymptomatic patient, totally normal exam, and if it was a stone cold normal EKG, I would be comfortable clearing them with knowing they're going to get cardiology follow-up. And I would encourage the dad, if he was very I don't know, to get more information. And specifically, I'll say, ask your cardiologist, should I have my children tested or should I have genetic testing? Because I think that then helps understand how concerned the adult cardiologist is that this was potentially genetic.
The CMR for those apparent coronary arteries.
So we always start with echo, and
Yeah,
if we don't feel comfortable that we can see them well, or we're suspicious, or even if we find it but we want more details, we actually usually go to a CT angiogram is usually our first line over MR. I don't know if Lars wants to speak to that more, but I mean, that's usually our practice.
Yeah, I'll try to make this brief. CMR is going to be really good and sufficient at showing you whether the coronary comes off from the wrong place. It's not going to be very good at determining whether it has a dangerous course, what we call intramural course, where it travels within the artery wall. It doesn't generally have that fidelity. That's why we typically skip CMR at that stage and go straight to CT, as Misty mentioned, because we know we're going to get a CT anyway. Where we are then going to do the MR regardless later on is for actually provocative testing. So we administer agents that stress the heart or change the appearance and mimic exercise. And we look at perfusion of the heart muscle and the way the heart muscle squeezes under that exercise-like conditions. We use either dobutamine or another test where we look at the perfusion is we give a drug that dilates the coronaries and sort of forces more blood flow, and that's called either adenosine or regadenosin. So a convoluted way to answer your question, for morphology, probably CT, and for provocative testing, a variety of things, including CMR.
I'll just add that anomalous coronaries are rare, but just because you have one doesn't mean you need to be restricted. And we are using provocative testing more and more to help. That's probably our best tool to decide who is actually at risk versus those that are not.
Yeah, especially with anomalous
Especially with
right.
anomalous right coronaries, which are even less suspicious of true pathology, if that makes sense. But good question. Yeah. Other questions for Dr. Carlson? Yeah.
Just to press you a little bit more on family history, are there any family history in an asymptomatic athlete with a normal EKG that you're like, no, for sure, you still need to hold until you see cardiology?
I would say with a normal EKG, yeah, probably not. Again, I usually tend to be less restrictive. So I don't know. I don't know if any of the other cardiologists have a different opinion, but I think I would tend to, even if I'm in the process of getting a workup, let a lot of those athletes play, just because I don't think it's, a lot of times we find out that there's nothing there. I guess the only one would be something like CBVT, just because they're going to have a normal EKG and exam. Because usually long QT and something, like I would usually expect there's going to be an abnormal EKG to at least tip me to restrict or not.
Thanks, that's super helpful.
Yeah, but I mean, usually you'll have a normal EKG, but yeah, I guess if there's a history of Brugada, you might want to do a provocative testing. So yeah, pretty rare things, but potentially.
Okay, great. Let's give Misty a round of applause. Thanks, Misty.